So to go to the subcostal IVC view, we have to get the subcostal four-chamber view first. And when you have the four-chamber view, you rotate the probe 90 degrees to the towards the patient head, so that the pointer is towards the patient's head. Here we have the subcostal IVC view. You can see the IVC draining into the right atrium, and that it's important to see the IVC draining into the right atrium when imaging the IVC, so that we have good sense whether it is IVC versus differentiating with the Iota. Take a deep breath and sniff. You can see the IVC getting collapsed with the inspiration, which is normal, and exhale. As the patient exhales, the IVC comes back to the bigger position, and you can see the common hepatic vein draining into the IVC right there. You can see the hepatic vein coming into the IVC. One more deep breath. You can see the IVC collapsing. The subcostal view for the IVC is going to be with a probe orientation marker tilt towards the patient's head and slightly to the right of the midline, and you can see that the IVC is right here and draining into the right atrium, and as he is taking a big inspiration, the sniff is collapsing, which is normal, greater than 50%, and the normal IVC size is around 2.1 centimeter. The other way to make sure it is the IVC is by seeing the hepatic vein coming and draining into the IVC right there. The hepatic vein is right here, draining into the IVC. And if we move the probe slightly medial, then we're going to lose the IVC and image the Iota instead, right here. You can see that the Iota is pulsating and the walls are thicker, and it's not draining into the right atrium. These are the markers for differentiation of the Iota, and color Doppler will show that you see pulsations in the Iota during systole, but not throughout the cardiac cycle, whereas when we image the IVC, color is going to show flow throughout systole and diastole. Another way to differentiate between the IVC and the Iota.